nursing homes and other long-term care facilities across the state. We know how important this is to residents and their loved ones, and today we'll review the guidelines for reopening and how we can work together to keep residents as safe as possible as the facilities reopen. We have two excellent speakers. Bill Monteo, who is the Director of Licensing and Certification within the Department of Health and Human Services, and Dr. Stephen Sears, who's an epidemiologist with Maine CDC and a clinical advisor for the COVID-19 response team. And we're very pleased to be a co-sponsor of this webinar along with the Maine Healthcare Association. So Bill can get started now, and thank you so much for being with us today.
All right, Bill, we'll turn it over to you here. I'm just gonna pull up your slides.
Thank you very much, Brenda. And just have a few brief slides that we'll go through fairly quickly as we work through the program here. To start with, the first slide just shows that the guidance that was issued by the state was drafted and developed through several state agencies, the Office of Aging and Disability Services, the Maine CDC, and our office here at Licensing, and addresses all nursing homes, ICF, IID facilities, and all types of assisted housing programs. Danielle, if you want to go to the next slide. I do provide, this guidance is publicly available, and you can access many of the documents that I'll be discussing at the state websites at these various links. You can also obtain the guidance directly from CMS's website as well, and you can always reach out if you have additional questions. I'm going to start talking with the federal guidance, which is the second bullet on the CMS memo. So Danielle, if you want to switch the slide. Thank you. In the upper right-hand corner, you'll see there's a reference QSO-20-30-NH, and that is how CMS actually produces or tracks their guidance documents. This is the most recent guidance on visitation that came out on September 17th, and it is drastically different than what many of the nursing home and ICF, IID facilities were dealing with early on, including in June and July of this year, where prior to this, there was a phased reopening process that required a lot of baseline testing and a lot of work on the facilities parts, and really still maintain limits on visitation to try and protect residents. This guidance established some core principles and some guidance that we'll go into to also address indoor visitation. And one of the things that it does note, and you'll see in the summary document here, the use of CMP funds, which is essentially federal fines that CMS issues on the nursing facilities, can be used with CMS's approval for various projects within the nursing homes. Early on in this pandemic, in late March, early April, Maine Healthcare Association and the Maine Long-Term Care Ombudsman partnered to use CMP funding money through a grant process to try and assist nursing facilities throughout the state in getting devices to help improve with visitation through electronic communication, such as iPads and similar types of devices. Maine has very limited CMP funds available, and those funds are reserved currently because they are below the federal minimum that we're required to have for emergency situations and closures, which we all hope we don't have to deal with. Danielle, if you'll go to the next one. In the CMS memorandum, these are reference core principles that CMS establishes, and they're pretty much the same as you've heard right along that has come out from state and federal CDC on infection prevention. Nursing facilities, ICF facilities, and assisted housing facilities are screening staff and residents, and federally, nursing and ICF facilities are required to screen everyone who enters, including their own staff, for any signs and symptoms of COVID. They're required to do temperature checks. They provide hand hygiene. Everybody is required to use face coverings. Social distancing is required to be maintained. There is requirements for signage throughout the facility for visitor education, and many facilities are still working on this. As you can imagine, this came out just about a month ago, but in trying to get signs produced and up and running in facilities takes time to order those signs and get them up and running. There is increased frequency for cleaning within the facility, increased utilization of personal protective equipment, effective cohorting of residents, which is the separation and use of dedicated COVID-19 care areas. In nursing homes in Maine don't really have the luxury of having extra space that they could dedicate as a COVID-19 unit for residents. So essentially what this means, and this is a federal requirement for nursing facilities, and they all have been working on drafting and plans and revising their plans of, in the event somebody tests positive, a resident tests positive for COVID-19, CMS requires the nursing facilities to look at cohorting of residents to reduce the spread of COVID-19. And that may mean if there are 2 people in a room and one tests positive, that one of those residents is going to be moved without their consent because of they are required to reduce the possibility of spread. So this is unique to this pandemic in that CMS has issued additional guidance, not covered in this, that advises facilities that they can relocate residents within a facility and transfer residents outside of a facility without their consent if it is done in the process of cohorting and trying to reduce contamination from this virus. So if they have a case in the facility and it's growing and expanding, they can try and isolate it in one wing or one unit. If it's continuing, they can look at transferring either the COVID positive cases out to a different facility that may be able to accept them, or the COVID negative out to a different, and this is all part of their emergency planning processes. There are very specific requirements for staff testing and the frequency of testing, and that's also something we addressed in our guidance, and that's available in a different CMS memorandum that we've provided you. But in Maine, the minimum currently is monthly testing of all staff. Residents are tested if there's a case of a positive staff, then we go and the facilities have consultation with Maine CDC, and they look at the feasibility or the need to do universal testing of everyone, just to ensure that the virus is not moving amongst residents as well. Danielle, if you could switch to the next slide, please. In the federal guidance and also in the Maine guidance, there are several facility factors that have to be considered. One, the most obvious in Maine, is the facility structure and design. As I alluded to earlier, nursing homes in Maine don't have the luxury of, Danielle, if you could go to the next slide when you get a chance, don't have the luxury of having a lot of extra space. So particularly many of our older nursing homes, we have actually several nursing homes throughout the state that were built and designed prior to the 60s. And that design function, although kind of more home-like than the traditional brick and mortar structure, really inhibits the ability to cohort and contain or create additional visitation or dedicated visitation spaces. So part of this new guidance that's come out for CMS is facilities are looking at, as we're coming into the winter months, to allow for indoor visitation. If they have facilities where there are several people that have roommates, is there anywhere that they could dedicate as a visitation space to allow for a resident and family to visit in a dedicated space that doesn't put the roommate at risk, which also addresses the roommate situations. Also the availability of personal protective equipment, both for staff as well as for visitors in some visitation cases. One of the key things that the guidance puts out is that visitation needs to be person-centered for the resident, which means the resident is involved in visitation. And I'll touch base on this a little bit further, but visitation in comfort care situations is driven by the resident's needs and not the family's needs. And that can be really distressful in some cases, but the physician is involved, as well as the care team, as well as the family, in trying to decide, is the visitation really what's needed for the resident? Because in a comfort care situation, it has to be the resident's needs that are being met. CMS still requires that facilities limit the number of visitors. And really, this is going to, how many are in the facility at any given time is going to depend on the design and structure of the facility, because we need to maintain social distancing requirements. And for many of you, you'll remember early on in this when there were limits in stores and the number of people that could go in based on the square footage of open floor space. CMS doesn't currently require testing of visitors, but as many of you have heard in the media, the federal government is providing these point of care testing devices to facilities, and CMS is encouraging facilities to test visitors, predominantly visitors that are, as facilities open up, that are in the facility on a frequent and regular basis. Not so much the person that may be going in once every 2 weeks to visit their family member, but more the family member that's in the facility every other day. And one key thing that isn't in the guidance, and I did highlight it here just so all the family members are aware, is there is still a requirement, and the facilities don't have a choice in this, that visitors have to adhere to the core principles of COVID-19 infection prevention, including face coverings, and any visitor that refuses to comply could be asked to leave and could be restricted from visiting again. And obviously the rationale behind this is to try and contain this virus. If this particular situation, if there's a family member that can't wear face coverings, then my recommendation is to reach out to the Ombudsman's program to see if there's something that, or actually first is to have a discussion with the facility, and second would be to reach out to the Ombudsman's program to see if there can be some assistance in kind of meeting the need and without endangering other residents or the resident at hand. Danielle, if you could switch. There's been a lot of discussion on compassionate care visits, and this is language that's directly out of the federal regulations. Early on, CMS described compassionate care visits as really being end-of-life situations, and so it was taken quite literally. They did provide a frequently asked questions document to give some additional guidance, and then in the September memo, they did add language to really clear that this compassionate care visit is not just an end-of-life visit. However, and it doesn't show up well here, but a compassionate care visit should be the result of a recommendation of the care team and approved by the resident's physician, because the intent of a compassionate care visit is to address an unmet need for the resident, or to try and change and provide the resident with the psychosocial needs to help them become their best that they can be and address any psychosocial deconditioning or depression that they may be experiencing. So it really does require the care team and the physician involvement, because what CMS is looking for is to validate that the visit is really to address the resident's needs and not to address a family's need because they miss their loved one. Many of the regulations in the nursing home world are resident-centered and resident-focused. And so this is, CMS, by putting this out, is really being consistent with their regulations, which does require that families, that residents be consulted as part of their visitation, and does require in a compassionate care visit that the physician and the care team really feel strongly that this visit is in the resident's best interest. And if you go to the next slide, Danielle. I'm not sure if the highlighting came across, but this is an earlier, the language one back. This is language from CMS's frequently asked questions dealing with compassionate care visits that really highlights the CMS encourages facilities to consult with state leadership, families, and the ombudsman to determine if the visit is conducted for compassionate care. What I want to point out is that second highlight where CMS states that they still believe visits should not be routine and allowed on a limited basis as an exception to restricting visitation. We also remind facilities and visitors that all actions should be taken to prevent the transmission of COVID-19 while the visits are allowed. And this is really focused on the compassionate care visit. So nursing homes can and should consider setting up appointment times to control the number of visitors at any given time. And they should limit the number of visitors in a compassionate care visit so that their total number of people or visitors in the facility, again, does not exceed social distancing requirements. So if you'll go to the next slide. Direct quote again from CMS. At all times, visits should be conducted using social distancing. If during a compassionate care visit, a visitor and the facility identify a way to allow for personal contact, it should be only be done following all appropriate infection prevention guidelines for a limited amount of time. And through a person-centered approach, facilities should work with residents, families, caregivers, resident representatives, and the ombudsman to identify the need for compassionate care visits. So it's highlighting if you as a family member really feel that your family member is deconditioning in the facility and that really needs to have more involvement, then you should raise that to the facility and to the care team. And if it's not being addressed, your next step would be to go to the ombudsman to bring up this issue and get them involved. Oftentimes, the ombudsman has been very successful at working with families and facilities to try and help facilitate the need and the visitation while still maintaining the appropriate infection control methods to prevent this from spreading. The issue here in the green, when CMS is talking about to identify a way for personal contact, there's been areas in the media where we've seen where some facilities have been utilized and it looks rather impersonal, but the use of plastic sheeting, for example, and arms where you're not actually having skin-to-skin contact, but you're still able to facilitate a hug to a family member without the risk of disease transmission. And that's what they're really alluding to here. And I will, if we'll go to the next slide, I'll spend some time going through the guidance that you can also get from our state website. And this has gone to facilities. So the guidance for, and you'll see at the top, this is for congregate homes, nursing and ICF, IID facilities. The guidance is identical for the assisted housing. So assisted living, residential care, the guidance is the same. And that in Maine, we are using, at the top, you'll see the facility status, and it references high, moderate, and low. And what we're looking at here is the number of new COVID cases per 10,000 resident population in a county over the last 28 days. And currently in Maine, we do not have any counties that are in the high level, which is 16 per 10,000. We have 3 counties that are very close to that, but they are not currently over. Which means that we have, in Maine, all of our counties currently are either low or in the moderate. And so what that means is that outdoor visitation is allowed in low and moderate and even in high cases. Indoor visitation, you'll see in high or outbreak status is compassionate care only, but in moderate and low, indoor visitation would be allowed. There are also, which I didn't put it in the slide, and I apologize, but it is in that CMS memorandum, requirements that nursing facilities do have to comply with for indoor visitation. And you can obtain that memorandum and to have it for yourself if you want to review it, but I will read it to you. It's that facilities can accommodate indoor visitation based on following guidelines. There have been no new onset of COVID-19 cases in the last 14 days, and the facility is not currently conducting outbreak testing. In Maine, if a facility has one positive COVID test on any of their staff, they start testing. So the presence of one positive COVID case in a staff member in a facility means that the indoor visitation would stop until they completed their staff testing and resident testing and determined if we are at an outbreak status or not. Visitors should be able to adhere to the core principles, which we reviewed earlier, and staff should provide monitoring for those who have difficulty adhering to core principles, such as children. Facilities should limit the number of visitors per resident at any one time and limit the total number of facilities in the facility at any one time. And facilities should limit movement in the facility so that we're not, again, we're restricting where people are going within the facility to try and contain any potential spread as much as possible. And there's additional information in that CMS 2039 memorandum that people can read and reach out to us or the Ombudsman if they have difficulty understanding it. Staff in nursing facilities, as I mentioned earlier, all staff are being tested. And in our assisted housing facilities, staff in some of the facilities are being tested, and those facilities are, and this is based on more of a risk assessment process, but staff in facilities that have predominantly Alzheimer dementia care, in residential care facilities that are part of multi-level complexes, and this is where it's a nursing home and a residential care facility within the same building, and in what's known as a private non-medical institute that has some high medical needs individuals. Those facilities are conducting staff testing of their staff. Other assisted housing facilities, such as the adult family care homes, group homes, are not conducting routine staff testing. They're really monitoring more for symptoms and risk factors and not doing the testing. But this guidance still does apply for the visitation purposes. So you'll see in the cases of staff, in high cases and outbreak situations, it's essential staff, and essential staff are the individuals needed by the nursing facility to meet and fulfill its mission to provide the care and services to their residents. And that does not include, however, beauticians, barbers. They're considered by federal as non-essential staff. And so in the cases of when can the beautician or a barber go into a facility and provide haircuts, any facility that is in a lower moderate case could have those non-essential staff in to provide beautician and barber services. In the cases of moderate, they really look at if it's beauticians are allowed in the facility. Other things they look at, is it really essential now, or is it something that can be delayed to, again, reduce the risk based on the situation at hand. And you'll see volunteers are not allowed unless we're in a low category. And communal dining and really activities we'll get into, but communal dining is in high cases, yes, with additional limitations, but it's really facilities have to, in a communal dining situation, still maintain the social distancing requirements that are currently in place by the CDC. Danielle, if you could go to the next slide. So essential medical visits, it's outside of the facility, if the resident is brought by the facility staff to or escorted to and from, that's permitted and allowed. In an outbreak situation, we're looking at essential medical visits outside the facility, not escorted, and this would be if you as the family member wanted to take the resident to the doctor's office. In an outbreak situation or a high situation, that would not be allowed. In a low or moderate, it would be. And what we're working on, and actually is a call this afternoon with CMS to get and try and clarify this, is the guidance is currently that, yes, if you as the family take your family member out of the facility and bring them to their doctor's office and bring them back, the facility is to handle and manage them as a COVID status unknown, which means that they are quarantined and kind of restricted to, in case, and the rationale is in case they have been exposed to the virus while in your custody or in your care. And part of that is because there is an overwhelming temptation as from family, and because the facility cannot be assured that the resident did not make any other stops, did not hug anybody, did not stop or see a neighbor and pull over and have communication with a neighbor without wearing a face covering. That's really the intent by CMS. What we have a call, I referenced this afternoon, that one of our associate directors is working with CMS to see if there's some way that we could utilize testing of the resident instead of quarantining for a 14-day period. So as with any guidance, this will change as more information becomes available and more knowledge about the disease. Group activities, again, if they're escorted by the facility or staff, yes, but there's a limit on the number of people, and there's still requirements for hand hygiene, face coverings, and appropriate social distancing. So for an outing in a facility van to just get out of the facility, the van cannot be full. It would have to be limited by the number of people. Group activities not escorted by facility staff, again, there are various limitations, and including day activities. Residents that go out to day activities or day support groups that are run by other organizations, those organizations, those community support services, have compliance obligations that they're required to comply with. And yes, screening of all visitors, staff, volunteers, etc. applies. And yes, source control, which is the use of face coverings as well as social distancing, does apply. So a couple of quick things that I did also want to highlight that weren't part of my slides here is we've had several questions regarding compassionate care visits and residents in the hospice. In particular, early on in this pandemic, CMS was very clear with facilities of the limit of visitation and really limiting 1 to 2, no more than 2 family members. And what they've done now is really, I don't want to say relaxed it, but looked at meeting the core principles. So in a situation where the resident is on hospice care and has multiple children, 3, 4 children, that there would be the allowance for those children to come in and visit, but not all at the same time. And that's something that is really addressed at the facility level based on the design and structure of the facility and the ability to social distance. So it may be that 1 or 2 children go in at a time and visit, and when they come out, another family member goes in, unless the facility has a space that they can move the resident to that would accommodate and allow for that social distancing. So it really is a case-by-case, facility-by-facility type of a situation, and that's where the involvement of the ombudsman really kind of helps to try and look at what are the options and what can be done. And we are, as we get closer to the holidays, getting a lot of questions about leaves of absence. Can a resident leave a nursing facility or an assisted housing facility or a group home and go home for the holidays and return. And that's something that we are still working on, because currently if a resident leaves and goes with family and returns, they have to be quarantined and isolated. And there's nothing from the federal guidance that really addresses the leave of absence scenario. And one of the things that we really still struggle with is the pandemic, as many of you are hearing in the media. There is a resurgence. It is, and we've been very lucky in Maine and very diligent in Maine about protecting everyone, but and we're trying to balance, as the feds are with this guidance, the needs for social interaction with the residents and still ensuring protection of other residents in the facility. So Danielle, if you get to the next slide, there's a couple of quick quotes that I just want to make people aware of that really kind of help guide what our staff are looking at when they're going into facilities. And this is from the PepsiCo CEO. Whatever anybody says or does, assume positive intent. You will be amazed at how your whole approach to a person or problem becomes very different. And when you assume negative intent, you're angry. If you take away that anger and assume positive intent, you'll be amazed. Your emotional quotient goes up because you are no longer almost random in your response. And that's because it's very difficult to be rational when you're angry. One of the things that I know is difficult and a struggle is, and I really believe this, is that facilities are not restricting access to be mean. They are really trying to the extent possible to protect the residents and the staff, because if this virus gets into a facility, as we've seen in many, it is very devastating. And so they are trying to do the best that they can, and I believe that they are trying to protect the residents, and in some cases they're going to the extreme. And that's where really, rather than get angry and get frustrated, the best approach and my recommendation would be to reach out to the ombudsman and really think about it as the facility is really just trying to protect your family member. And if you're dealing with somebody that's just not being rational and you can't reach and have an open discussion, then the best recommendation that I would have is to really reach out to the ombudsman to see if there's something the ombudsman can do to assist in kind of helping to mitigate the situation. Calls to licensing, we do investigate if they meet the regulatory violation, but we don't mitigate and resolve the situations. Our role is really of, did they violate the regulation, yes or no? If they violated the regulation, we issue them what's known as a citation or a statement of deficiency, and the facility gives us a plan of how they're going to correct it going forward. The best bet is really to reach out to the ombudsman to help address the situation at hand. And so the assisted housing guidance, as I referenced, is really the same flow chart or table that we just reviewed and saw. The only difference in the assisted housing is they don't have the federal regulations behind them. And this is really very new to assisted housing. Prior to our putting out this guidance, we've had discussion about this with assisted housing providers. CMS has put out a lot of guidance and a lot of federal requirements for nursing homes. Assisted housing, this guidance is new, and it's taking a little bit of time for many of these providers to get testing and the testing process up and running, and to get policies and procedures and processes in place. So what we are looking for is that providers are doing due diligence to try and come into compliance. And I would just ask that, everybody be patient as we kind of work through this. And if there's areas of concern, reach out to the ombudsman if you don't get any resolution with the provider themselves. And if the ombudsman doesn't get any resolution or can't, they're not afraid to let us know as well. With that, Brenda, I believe Dr. Sears would be the next.
Thank you so much, Bill. We have, this is Danielle from Maine Healthcare. We have lots of questions in chat. We're going to hold those to after Dr. Sears. So for now, I'm just going to go ahead and pause here, spotlight Dr. Sears, and I'll turn it over to you.
Off mute. There. How's that? How's that? You know, you'd think after being on Zoom for 7 months, I'd still remember you have to click the little red button on the bottom to come off. So thank you for inviting me today. Bill has covered a lot of ground, and I do know that there's going to be lots and lots of questions. So what I was hoping to do is to just kind of bring us back to the beginning and roll through to where we are now, not so much from the regulatory standpoint, but from the disease and the epidemiology standpoint. We've come a long ways. March 12th of this year was the first case of COVID in the state of Maine. And as of today, we cumulatively have diagnosed 5,962 cases of COVID. We have about 25 to 35 cases a day still. And we have some individuals who are in the hospital, and generally we have a few people who are in ICUs, although today, thankfully, we do not. We have been seeing a slow uptick in the number of cases, although we're trying very hard to keep things where they are. It's been 7 long months, though, for everybody. And there's a lot of fatigue, there's a lot of frustration, and I think everybody recognizes that. But when I sort of look back and I say, what do we need to do? And we still need to do the same things that we were talking about in March, which is what the epidemiologists will call them non-pharmaceutical interventions. What that means is we're not treating with drugs. We're using basic public health interventions to try to minimize the transmission of this virus, and that is the things that we all know, which is wearing face covering when we're in public or anywhere near other individuals. We need to maintain social distancing, and we need to use good hand hygiene. That hasn't changed, and we continue to really have to emphasize that in long-term care facilities. But let me emphasize a little bit of what we've seen over the last 7 months in long-term care facilities overall. And when I say that, I'm just looking at nursing homes, and there are 93 in the state. I think it's important to recognize that we have had outbreaks in 25 out of those 93 during that period of time. You know, that's 27% of all long-term care facilities had an outbreak. And from what we call an outbreak from the Maine CDC is anytime there are 3 cases, whether it's 3 staff, 3 residents, 2 staff, 1 resident, or whatever. If we see 3, then what that does from our standpoint is we intensify our investigation. We do universal testing of everyone, both staff and residents, and we identify any other cases which have been perhaps not seen or not identified yet. And in most of those cases, we in fact do find more cases. I think Bill mentioned, and I think it's written clearly in the CMS guidelines, if we see 1 case, we recommend universal testing. If we see 3 cases, then we call that an outbreak. That will trigger us actually performing testing on a weekly basis for a period of time until we can get to a point where we're no longer seeing cases. So, as again, what I said is we've seen about 27% of all long-term care facilities in this state have had outbreaks by those definitions. Right now, there's still 4 long-term care facilities that we are working with who are what we say in the middle of an outbreak or getting towards the end of that. And we have 3 more that are of great concern. And that's because COVID in this state, I sort of think of it as little brush fires. We try to control it overall, but all of a sudden there's a little brush fire, and we see an increase. And then sometimes if we see an increase in like a county, we may then see transmission within, a school or a long-term care facility. And so I think you all have probably heard lots about an outbreak that occurred in Millinocket during the beginning, sort of middle part of the summer. That was associated with several other outbreaks around the state and spread throughout the state, but we also had 2 long-term care facilities that were associated with individuals who could be traced back to that. And so that's what we see a lot. And I emphasize that because as we move towards opening up and having increased visitation, which everybody is really has been looking for a long time, we just have to continue to be careful. And that's why we have the metrics that we have developed, which try to help us determine what we consider to be low, moderate, or high transmission in the state. And the chart that Bill went over is really all of the guidance is based off of where a facility is and where a county is. And when we talk about transmission rates, we're really talking about county transmission rates. And as across the top of that chart, it may have gone by quickly, but it's the rates we use are anything over 16 cases per 10,000 is considered high. Anything between 8 and 16 is considered moderate, and anything low is less than 8 per 10,000. And so why do we use that? Because that's actually a number that's different than CMS. CMS uses what's called a positivity rate, and that has more to do with the number of tests that are positive out of the total number of tests that are done. We have found at the Maine CDC and in Maine that the case rates are far more sensitive indicators of what's actually happening within the communities and whether we are seeing transmission in workplaces, in schools, or in, as we're talking here, in long-term care facilities. And a lot of times that's because we're seeing cases in individuals who work in long-term care facilities, and unfortunately they may have gotten exposed in the community, and if the community rates are high, that's more likely to happen overall. We are very fortunate in Maine that we have never had really high levels of transmission. We've had what as I said, as I call them, brush fires. Sometimes they were really fairly significant fires, but we were able to get control of those with a lot of epidemiological investigation, contact tracing, increased testing, and identifying individuals, then quarantining them. And that's kind of the hallmark of what we do from the CDC standpoint, and is what's being done all over the country. Right now, as Bill mentioned, there are 3 counties that are, actually I think there are now 4 that are on the moderate level, but most of those are all on the decline now. We know, for instance, that York County was in the news a lot. We had a lot of transmission there. That was it was at quite a high rate, and it's now fortunately going down. And we look at this on an every 2-week basis, although for the rates for long-term care, we look at a 28-day basis so that we know that we've really got stability in the case rates, and we're fortunately seeing that declining overall. And I'll be happy to go through that if anybody wants to, has more interest in how we get to the numbers and why we do what we have, developed as far as our determination of what we consider to be the more likely scenario for transmission overall. I think it's important also just to recognize, and I do this only because in long-term care, we are dealing with the most vulnerable populations. And we know, unfortunately, that's where we've seen the most significant amount of morbidity and, unfortunately, mortality. If we look at the state of Maine, we've had 146 people who passed away from COVID. 87 of those were in long-term care facilities. That's 60% of all of the people who passed away in the state. Or looking at this another way, if we look and say that of the 87 have passed away, of the 456 total cases in long-term care, that's what's known as a case fatality rate. That's basically 20%. So 1 in 5 individuals who get COVID in long-term care have the greater, are likely to have passed away in the state of Maine. And I say those all because those are all those are high numbers. They tell us that, in fact, the protections that we want to provide to individuals in long-term care are important. So even though as we open up and we become allowing much more visitation, we all have to really take our roles seriously as we visit our loved ones. We need to make sure that we use good protection, we use the distancing and the masking, and if anybody is feeling at all unwell, they really should not go and visit. And the facilities will try to screen people out, but I think we start by screening ourselves out. And why are we concerned? Another reason is, unfortunately, as Bill mentioned, COVID is surging around the country, and it's surging in the areas, even in New England, where we've seen it was under control for a while. We're seeing increased rates in Massachusetts, increased rates in New York, and clearly, I think we've all heard about the very significant increased rates in the Midwest. So COVID's not going away. It's not going, and if anything, we have probably greater concern as we move into the winter. We also have concern about influenza, and for those who have not gotten their flu shot, this is a perfect time to go out and do it. We want to make sure that everybody gets vaccinated against flu so we can minimize that as a potential additive problem on the top of COVID. So COVID is going to be with us even as we begin to open up, and we just all need to work together to try to find a best way to be as safe as we possibly can. And I think the guidelines that Bill has provided, the numbers that we are looking at as far as what constitutes concern, what we can do safely at different places, at different times in the state. And I think the final thing is we have to recognize that although a county today may appear to be at the low rate, it can change, and it can change very rapidly. Right now, we are looking at Waldo County because of an outbreak that's ongoing there. We've got 40 new cases, and our suspicion is that number is going to be going up fairly significantly in the next number of days. So Waldo County, which has been a county that's had very low transmission rates for quite some time, is all of a sudden finding itself with increased transmission. And that's what we've seen happen. That's what we saw happen in Penobscot County with the trouble in Millinocket. It moved to York. And so the point is that COVID, it's with us, it's in every county, it's around us, and we may well all have some fires that go with that. So I will stop there, be happy to answer questions, and I know, as I said, Bill is also very interested in getting questions answered, also answering questions. Thanks.
All right, so I am just going to start kind of towards the top and do my best to kind of field them out to whoever I think it's most appropriate to. I won't pick on you, Bill.
Please do.
So one of the first questions really looked at the differences between kind of family and staff and touching and handling residents. And I know that both of you have kind of alluded to the fact that this is a delicate situation. And so wondering, maybe Dr. Sears, if you can talk a little bit about the reasoning behind the restriction of families and visitors and the differences between staff and some of the protective measures we put in place for the residents.
Sure. I think that the one thing we've learned is that that even when we test people, even testing people today is only as good as today. And what I mean by that is there's a lot of people who have COVID who have no symptoms, and their test actually may be negative because if the test is much better at picking up people when they have more virus. And we've just found that even when we think we've done all of the best protection we can, there's probably a little bit more that we need to do, and that's trying to keep people apart still somewhat at this time to try to keep control. And I know it sounds like, you know, belt and suspenders in some ways, like we're trying to do everything, but we actually are, because as I mentioned before about the vulnerability of this patient population. And Bill, I didn't know if there's anything you wanted to add.
Yeah, I think the other is that the staff in the facility, there's a testing frequency, as Dr. Sears alluded to, is, you know, many of the cases that have involved staff getting tested who have tested positive didn't even know that they had the virus but because of the frequency of testing and also the training and monitoring of staff, it's more likely to be picked up than with a family member that gets tested, you know, on occasion. Now, the concern about, well, geez, if a family member was willing to get tested at the same frequency, could they then go in and provide care to the resident? That CMS looks at this really differently in the nursing home world, and essentially the nursing homes have regulatory authority and responsibility to keep the residents safe, and they're really, it's not that they're trying to prohibit families from going in and seeing their family members. They're trying to really kind of contain the number of people in the facility at any given time, because that will reduce the probability of something coming in as well. So, and the same kind of applies towards students. We have had people ask, well, geez, why are CNA and nursing students allowed to go in? And the reality is, if they weren't, we wouldn't have anybody to fill the void when the virus breaks out. You know, in a facility where staff test, and we do, we've seen this where facilities that have an outbreak lose a large number of staff for a period of several weeks because they've tested positive. Even though they're not symptomatic, they can't work. So without qualified trained individuals to help support the facility and that really qualified pool of individuals to help, there's going to be a crisis where we're not going to have enough people to meet the needs, and facilities are going to be faced with a difficult choice of closure and sending residents. And in Maine, there is, as many of you know, there's not an overabundance of nursing home beds. So, you know, it's a delicate balance that we're trying to meet.
Sorry, couldn't get myself unmuted.
That's okay. I will also add, Danielle, there are other federal and regulatory requirements such as OSHA that come into play. And the staff and facilities have to be medically screened to wear these N95 respirators and fit tested. And so it's a little more in depth than just putting on a gown and gloves and wearing a mask. And there's a lot more regulatory oversight beyond our agency.
So the next question is one of those questions that we keep getting around timing, and when are we going to be able to open up business as normal in our facilities, in our homes? And I know you've alluded to the fact that COVID isn't going away. It's here with us. And I know that you folks, the CDC and CMS and DHHS, have worked really hard to create that rubric that kind of designates low, moderate, and high. So any comment on the timing other than we need to meet the criteria for those designated, where the facility would fall in the designated level of risk?
Yeah, I'll start now. Let's see if Bill wants to chime in a little bit. Yeah, what we're trying to do is strike a balance between the most compassionate and, you know, and care, as well as the ability for people to have social interactions with their loved ones, with the risks that this virus unfortunately brings. And it's not, when I hear the question of when will we be normal again, I don't like to answer that in the way that sometimes first comes to mind for me, which is we really aren't going to be normal for quite some time. But I think that's really true. Normal, which meant that we had unrestricted access and and the ability for people to go in and out of facilities, for residents to have a lot of social interactions, for family members to have a lot. That unfortunately we're in an era right now where social distancing, good hand washing, and face coverings, except when we sort of have very small known groups of individuals that we sort of live at home with, is a problem, and not one that we can easily get around if we want to try to keep, as I said, the fires under control. And what I've seen is when people begin to say, well, maybe this doesn't apply to me, or this doesn't apply to this situation, that's when we start seeing outbreaks. That's what we've seen in, pick on a wedding, pick on a church service, pick on a workplace, pick on anything where we've seen people get a little lax in their protections, or in keeping up the protections for their fellow citizens. Really, that's what we're protecting, other people from us, and then we're being protected from them. When we see those start to become inconsistent, we unfortunately start seeing outbreaks. Again, fortunately in Maine, we've been incredibly fortunate to keep this under much better control than it has been in other parts of the country. But we're right, we are sort of on the edge right now of having rates going back up, and we really would hope to be able to keep that in good control until the next, if there's a breakthrough with a vaccine, that's great. If not, maybe there's a drug that comes out, maybe there's something more that's coming. But right now, what we know we need to do, we need to continue to try to implement as much as possible. And I'll sort of leave it at that. I don't like to sort of preach too much. I really try to make sure that we all understand that we're in this together, and what we can do is the things that we can do together. So thank you.
Yeah, and it is difficult to predict. I agree with Dr. Sears. When people ask me when is it going to return back to normal, it's the response that I have is I can't see that horizon at this point. I think things are going to get better. We are going to have better tools as they come up with vaccines and other treatments, and things will continue to change, as we've seen. In the last 6 months, we've gone from extremely restrictive in regards to visitation to, this most latest guidance is allowing for more visitation. But I don't see a short period that there's no way that we could say in the next 6 months things are going to go back to where they were pre-COVID. But I do think things will continue to get better, and I think we have to really kind of be vigilant and really go with the attitude of everybody is trying as best they can to strike that delicate balance between the psychosocial needs and visitation and protecting people so that we don't continue to have a high death rate.
All right, thank you so much. So I think this question is relevant not just to our home providers, also to families, and it's around parameters for visitation. So I'll throw it to you first, Bill. In terms of visitation, can the facility designate specific locations for visits to occur, and specific time of day or time of week for visit schedules? So I wonder if you can just go into a little bit around how facilities are able to kind of manage that process and what some of the boundaries might be around setting that up.
So that's part of the CMS guidance, is that facilities are required to have a plan for testing. Then they're required to post and make signage available for visitors. CMS has stated that they do want to limit still the number of people within a facility for social distancing purposes. And CMS does encourage, as we do with assisted housing facilities, that if they have the ability to create a dedicated visitation space, that's the ideal. If it's being used by multiple people, then they have to allow for time to clean, touch areas between. So, you know, it is reasonable to expect that facilities would establish limits on the number of people within a facility based on their ability to clean and disinfect and provide appropriate PPE, and based on their facility design and needs. They still have to have sufficient staff to meet the needs of all the residents. There are a lot of very well-intentioned family members that, you know, that want to, when they're there, help their family member. And what CMS, you know, expects is that it's still the facility responsibility to ensure that that resident is getting their needs met. And it's a delicate balance between helping your family member and crossing the line between you know, touching and putting them at risk. And part of it is that even as often as we're tested, we never really truly know. If I'm tested 3 days ago and I'm in a facility visiting my family member and I reach out just strictly unconsciously and out of habit and give them a hug and a kiss, that I may not have given them something, and then that would be devastating for me. So, you know, it's, but in the short answer, yes, facilities can limit the number of visits. They can establish visitation times and guidelines. The requirement is that they would make that known to the family members, but they still have to ensure that they're meeting the patient-centered needs of the residents. So, and by that I mean if a facility establishes visitation times and they're only in the early morning and there's a resident that is known to not give up until noon because that's their preference, the facility has to address that visitation for that resident to meet their needs.
Thank you, Bill. And I'll just say from Maine Healthcare, we work closely with the facilities and assisted housing homes, and there's some really creative and inventive ways that facilities are facilitating designated visitation areas. And this is as hard, I think, for the staff as we recognize it is for the families. And the facilities are working really hard to try and come up with good solutions that follow the guidance from the CDC, follow the regulations from CMS, but also allow for families to visit with their loved ones, because we want families to visit with their loved ones. So creative ideas such as plexiglass rooms that are being kind of partitioned out of lobbies, and designated doors from side entrances that are being designated as visit only areas that can be easily sanitized and disinfected upon one family exiting and one family entering. So my thought is that those types of visit areas will increase as facilities are getting those on board. So the next question has to do with compassionate care visits, Bill, and it's around the frequency of compassionate care visits. My understanding from the guidance is that they shouldn't be regular, but the question came up is, could they be perhaps once per week as a compassionate care visit if it's designated and falls within the parameters of the definition of compassionate care?
Yes, but that would be something that the physician and the care team would need to work with the family on, because CMS, what CMS is really alluding to is compassionate care visits shouldn't be that I go in twice a day, every day, 7 days a week. But it really has to be driven by the patient's needs. And if the patient needs visitation more frequently and the family member is willing to do that, and the facility, the medical director and the care team feel that that would be in the patient's best interest, then yes, it could occur more often than that. It could be twice a week. It could be weekly. But it's driven solely by the needs of the resident and the family and the physician and the care team's agreement on what is in the resident's best interest.
And there were several comments around getting copies of the slide deck, Bill, that you provided. Thank you so much for your effort in putting that together. I'll make sure that that gets turned into a PDF and gets sent out to the registration list as a part of the follow-up for this event. To follow up, and maybe this is a question for Dr. Sears, but in terms of someone who leaves a congregate care setting or leaves congregate housing and then is hospitalized, is there best practice or guidance around what's required for quarantine upon their return to the home?
Yes, typically facilities often ask the hospital to test the individual before they leave, but then even when they arrive, they put them into quarantine for a period of time. It depends on the facility. Some facilities have adequate space and they can easily quarantine someone for 14 days. And you sort of ask the question, well, why are they doing that if they're testing them? The test will tell you right at that point in time whether the person is infected with COVID, but they could have been exposed anywhere up to 10 days before, because we know the incubation period of this virus unfortunately is 14 days. So someone could get exposed today and not show the virus for up to 12 to 14 days. The most typical is day 5 to 6, but that's the reason that the individual would still be quarantined if they've been in a hospital for a period of time. Many of the facilities have places where they are able to accept somebody from a hospital easily and keep them in what's sort of called a COVID unknown situation, where they use appropriate precautions and wait for the 14 days to finish before they put them back out into their general ward overall, or the general living situation. And I think that that's sort of the best guidance. Sometimes there's a little mix of that. Sometimes people will do testing for a couple of times or maybe 3 times to see whether they can get the person to get out of the COVID unknown rooming for a little bit earlier, and that's possible depending again on what the time frame from when the person was in the hospital to when they arrived at the facility.
Great, thank you so much. Bill, would you be able, and I think this kind of goes to definitions of essential and non-essential visitors, do you think you could just generally address services like podiatry, dentistry, some of those other healthcare providers, and whether or not they would be considered essential or non-essential, and where that might fit into the grid that you provided earlier?
Sure. So podiatry and dental visits and other similar services can be either essential or non-essential depending on the service that's being provided. For example, a dental visit for just a general cleaning would be deemed non-essential because that's something that could be delayed without significant risk to the individual. Dental visit to address a impaction or a serious cavity or a filling that's fallen out or something that is inhibiting the resident's ability to eat and causing them a lot of pain would be an essential visit. Likewise with podiatry, a podiatrist visit to do a routine inspection and toenail clipping would not be as considered essential. But if that was a diabetic situation and it was impeding or putting them at serious risk for other complications, it could be essential. And it's really up to the physician and as well as that service. So if a family or a resident feels that they really need to see the podiatrist, they should be having that consult with their care team and the physician can order it as an essential service. And so that's kind of, it's a gray area about when is it essential and when is it not. But in general, if it's a service that's routinely provided that can be delayed without a significant impact to the resident's overall health and well-being, then it's non-essential.
Thank you. So in terms of day trips or outings with family, is there guidance or best practice around when a resident goes out with family on a day trip, and whether or not they should be tested or then quarantined. How might families and facilities handle when a resident would like to take a day trip with their family?
So that would be if you go back to that table and look at, even though we've put it under group activities, but essentially activities not escorted by the facility or a known provider is what would apply. So in the case of a resident that went out on a day trip with a family member, they would have to be quarantined and treated as an unknown COVID status upon their return. But it really begs the question of why we're doing this in the first place. Is it to meet the residents' needs? If it's in a nursing facility, there's probably going to be a higher level of review because the risk factor to the nursing home residents where they're more compromised is going to be higher if this individual leaves and goes on a day trip and goes into a restaurant that's not following social distancing requirements or CDC guidelines for restaurants currently. That individuals could contract something and not even know it and then bring it back to the facility. So, you know, this is where when we really look and ask families and residents to really consider carefully what they're doing and why they're doing it and what's the level of risk both to that family member and to other residents within the facility. But under the table, it would be anytime somebody leaves the facility without facility staff to sort of monitor the situation, upon their return, they would be treated as a COVID unknown and would be expected to be quarantined for 14 days and monitored daily for symptoms.
And to continue with that, are there recommendations for staff members that are off duty? There's a question around, you know, obviously staff are doing what we need to do when we're coming in for shifts and out for shifts, but there's time when they're also in the community. So are there recommendations from the CDC on staff, and has that been provided?
I think the recommendations really are similar to what they are for everyone. It's not directed at the staff of a facility, other than that the staff should know that the facility they work in have people that are very high risk. But all of us need to behave and do the things that we know that decrease the likelihood of transmission, because whether we catch it or whether we give it to someone else, it's the prevention that we need to do is the same. And so, no, there's not a specific guideline that says if you're working in a facility, we're going to check and see whether, you know, you're wearing face coverings when you're out in the community. I think that the risk is, as we all know it, and that we try to emphasize to individuals who work in those settings to try to minimize, but with really no more so than everybody else, because we could pass it on to someone who's at high risk very easily without knowing that. So I think I'm understanding the gist of the question, but there's not a specific guideline from the CDC that is written for the staff outside a facility.
And on the regulatory standpoint, Danielle, our regulations are for facilities and not so much for the individuals, and there is nothing in the regulation that requires facilities to look out or reach out to what their staff are doing when they're not in the facility. However, what we're seeing is, and we are getting, is complaints from individuals letting us know that they're seeing on social media a staff person in a facility who is at a party and not social distancing and providing photos of evidence. And we are looking at with facilities of if that is made aware to the facility, that increases the risk. And so the requirement really is that if a facility becomes aware of behavior that increases, that they have this as part of their planning process of looking at what interventions they can take to mitigate that risk to the residents of the facility, because it's a very difficult labor management issue that you know was not really part of the CDC or our oversight. But all we're looking at is if a facility is aware of something that's occurring outside of the workplace that increases that employee's risk of contracting a virus, that the facility take that in mind and use that as part of their risk mitigation strategy, and have a policy or procedure to address it. And it may be that that individual gets reassigned to different duties, or that they're required to wear PPE. But that's what we look at.
I think the only other thing to add to that is that if that staff are being tested, depending upon the community that they're in, all staff are going to be tested at least once a month, or twice a week. Twice a month, if they are in one of the higher risk counties, or if there is a case within a facility, then universal testing is usually done weekly until everything is negative. But that's really not addressing per se what I think that question was asking.
So this is actually, Bill, a question directed at you from facilities. Are assisted living providers needing to send their policy and procedure to licensing DHHS for approval before putting it into place?
Not for approval, but we would ask that they send it in just so that we have a record that they have it, and then we have it on file.
Thank you. So there's a question for Dr. Sears. What exactly is a quote unquote case? Is that just a positive test result, or is it the presence of flu-like symptoms and shortness of breath? What would be the CDC definition of a case?
Great. A CDC definition of a case is a positive culture. So positive PCR, not a culture. PCR. So it could be someone who is asymptomatic. It could be someone who is who has symptoms. So I appreciate the question, because we all use jargon that is specific for our own area. And so case is sort of standard jargon that we use in epidemiology, but it is any positive PCR, which means the person is infected with COVID, with the virus that causes COVID disease.
And to follow up, Dr. Sears, there's been a request for a 5-minute YouTube video on visitors and proper visitation, or ways that we can safely visit. I would love to work with you on that if you're willing to do so.
I'm willing to work on it, but just remember, I mean, I'm an old guy, so YouTube is like something I kind of like. I go, yeah, that's like the thing that people like make little videos with. I know that much about it. So, but I think that what's the CDC try to do? We try to provide information that is credible and reliable and useful for people. So. I'm sure that we can see if that's something that could be accomplished if we think it's going to be useful.
Yes, I think so. Yes.
You're hearing yes from across the.
Yes.
Yeah, we're gonna film this from my basement, which is where I'm sitting now. Anyway, that's.
We will, we've been talking with Brenda here at Maine Healthcare and the Ombudsman about doing a partnership around getting some materials put out to families around safe visitation. And I love the idea of maybe having the CDC and Bill, from your point of view, DHHS, and have it be a collective project. So I'll reach out between Brenda and myself. We'll be reaching out to you. Thank you for the suggestion, who wrote that in. In terms of, and this is another question I think probably for Bill, with regard to entertainers or folks that are providing entertainment for residents, could they do so behind plexiglass shields or other creative ways of protecting the resident, but still bringing entertainers or entertainment into the building?
Yes and no. So it depends on the type of entertainment. So, and also depends on where in the facility it's going to be, because the requirements still would exist for social distancing and number of limitations. So if we were a facility was bringing in an entertainer and had 32 residents, they would need a room large enough to accommodate all of those people with 6 feet in between all of them, including the entertainers. If it's somebody that's singing and providing voice projection, then our recommendation would be no, not inside at this point. We have seen facilities doing outside entertainment where people are singing and they're 20 plus feet away from the residents. That's okay. But even the utilization of plexiglass indoors, in part because of the air handling systems, would not be a recommendation at this point. And I'll let Dr. Sears add to that.
The only thing I would add is that the reason for this is there have been several significant outbreaks in choirs and in other situations where people sing. Singing sort of vibrates the vocal cords, which then creates more projection forward, and with particles. Instead of the 6 feet, it goes at least to, we think, 14 feet plus, probably more than that. That's why the guidance was originally for outdoors, but even significant distancing, and that's mostly because of the air dispersion and the UV light. So I know that there are guidelines that Hollywood has been working on, trying to figure out how to actually create and still make either movies and or TV shows. And there's a lot that can be done with devices, so somebody doesn't have to, I mean, they can be in another room and you can actually hear their voice very well. But right now, as Bill said, it's the reason for not having people in the same room with people specifically singing, more so than probably other types of entertainment, is that they project much farther than what we can usually control in an indoor environment.
Another question around visits and nursing homes' decision to allow or disallow. I'm wondering, Bill, could you remind us what the criteria would be if a facility couldn't meet their ability to provide visits? Are there circumstances that would prevent them from being able to provide visits?
Yes, depending on the design and staffing within the facility and the availability of PPE. But I would say that anytime a family is denied visitation, that they should meet with the facility to really understand why, and if an accommodation can be made. And then if they're unable to really resolve it, then to kind of bring the ombudsman, reach out to the ombudsman. And oftentimes the ombudsman can help kind of provide something that neither party has thought of before, that meets both parties' needs and still allows for the safety of the resident and other residents within the facility. Sometimes they can't, but at least they can help, clarify or understand. And then there's times where it doesn't pass the straight face test and licensing has to get involved. And, if it gets to that point, we're really looking at it from the regulatory standpoint, and if it violates the regulations, we issue the citation and the facility will give us a plan to fix it. But it really should take that progressive step process to try and, we encourage it to be resolved at the facility level between the facility and the family. And if not, then reach out to the ombudsman.
Yeah, I was going to echo that same exact sentiment, that we've seen a lot of successes in the last 8 months where the ombudsman has been able to come up with creative solutions between families and providers. So at any time you feel like, you just need someone to help balance that out, please reach out to Brenda and her team at the ombudsman. So there was a question around essential family caregivers and the potential for having a program similar to that to meet the need of potential staff shortages now that we're doing kind of routine testing. And just to give some context, Minnesota, I believe it started in Minnesota and Michigan, created an essential family caregivers program where family members would be designated as essential personnel that could go into the visit and provide, go into the facility and provide care for their loved ones. So I guess my question, or maybe the intent of this question is that a program that could be considered here in Maine? Is there obstacles to that, or is it something that that we could pursue?
It's something that I think we can certainly discuss and look at in the event that a facility is in an outbreak status. Part of the reason I kind of hesitate a little bit is because of the testing, screening, monitoring, and also because even though you know, the families are doing this really with the best of 10, and facilities could allow it with the best of intent, they could still result in a federal citation for insufficient staff, because unless it's worked on and approved by CMS would view that as a facility failure to provide sufficient staff to meet the needs of the residents. So I think that's something that would take a little more discussion, and it's a good concept and something that we should follow up on. But right now, it's not something I would recommend, but it is something we can look at.
Thank you. A question about, you know, we've talked a lot about guidelines, and both Dr. Sears and Bill have provided quite a bit of information around kind of the parameters for allowing indoor visits and some of the barriers that facilities may face. Ultimately, even if a facility is in kind of that moderate or low category of risk, the question was around it sounds like the facility still has control on whether or not they're able to provide all of the measures to be able to have and allow these visits. Is that true?
If the facility is denying, even if a facility is in a county of low transmission, which in Maine is based on the case counts of less than 8 cases per 10,000, and they're denying visitation, if it's a nursing facility, the denial would have to be consistent with that QSO 20-39 memorandum, where the facility can point to either a core principle or in indoor visitation guidance that they cannot meet. If it's an assisted housing facility, we would have the, you know, it really begs the question of what is the issue. So it's not that facilities can have a blanket to restrict visitation, and I don't believe any of them are really looking for that. I think what the struggle is really making sure that they're allowing for visitation and still meeting the needs and providing appropriate protections, because facilities are very cognizant of the catastrophic effects of this virus, and they really want to take every due diligence to protect residents. So if there's a denial of visitation, it should be explained to the family of why. If the facility sets visitation hours during certain hours, it should be based on some reasonable rationale as to why they're doing it. It may be because of staffing. It may be because of the availability of rooms. And, you know, when I refer to staffing, it's also staffing to clean and sanitize after the visitors have come and gone. So, you know, I think we have to really look at and give some best intentions. And if the facility and family are unable to reconcile a visitation issue, then they should bring in the ombudsman to try and look if this is something that can be resolved at that level.
Thank you very much. So we're getting towards the tail end of the questions. The one question regarding the physician determination for compassionate care, is the physician that would designate that or determine that limited to the attending physician at the facility? So I'm assuming perhaps the medical director, or would other physicians that are caring for the resident be able to weigh in on that determination?
You know, what we're looking for is the physician that knows and is treating this resident. So, you know, in the medical director of the facility really has oversight over the medical care of all residents within the facility. But it should be that resident's physician who sees that resident and writes the resident's orders and is responsible as part of the care team for that resident's care. That's the individual, and the reason for that is that's the individual that would know that resident and understand that resident's needs and the needs that are trying to be met with the care team. In the event that that physician is unavailable, then it could be the medical director. But the genesis behind that is to make sure that the visitation is addressing the psychosocial need or the unmet or the deconditioning of the resident that needs to be met.
All right, last question. So this goes back to kind of the determination of whether or not visits can occur in a private room versus a general visitation area. If residents have private rooms, can they have a visit in their room, or should they be in community space? And I believe that the answer probably has to do with whatever the facility has determined is most safe, most appropriate for their visitation plan, but I'll let you folks answer that.
Yes, a lot of that depends on the facility design and structure and where the room is. So for example, a resident in a private room that's in the back of the facility that you have to walk through three different wings to get to would not be an ideal place for visitation if the facility created a room closer to the front door that would limit the amount of walk through within the facility. That would be the preferred. So there are a lot of variables in that we look at but if a resident is in a private room and the facility is denying visitation in that room, there should be rationale for why they're doing it from an infection control standpoint.
All right, so thank you so much, both of you, Dr. Sears and Bill, for going through all of the questions. I think we actually were able to capture them all, and I'll turn it over to Brenda for.
Could I make one one? Because
yeah, of course.
I always remember all the things that I should have said when I was like talking, but the one thing I really wanted to emphasize is, you know, as I said, we have been involved with at least 25 different outbreaks in long-term care facilities. And I've been on probably most of those phone calls with the people who work in the long-term care facility, as well as other epidemiologists. And I've been really impressed with how much the facilities want to do the right thing, and how much that when we provide guidance, they follow it and they try to do the absolute very best they can. And it's been a very heartwarming and positive experience that we've been able to really communicate effectively. And just so people understand, when we have an outbreak, as soon as we know, we call. We have usually all of the senior leadership as well as the medical individuals from the facility as well as our group. Then we continue to meet as needed, oftentimes, you know, Monday, Wednesday, Friday, or more often than that. And as I said, it's been really a good collaborative relationship that has gotten us to this point. And I just really wanted to thank the facilities for being able to help us get to this to get to the levels that we are. And we're actually in, as I said, we're in pretty good shape in Maine, where we got to always be vigilant, but just wanted to make sure I mentioned that.
Thank you so much, Dr. Sears. And you know, thank you all for the work that you've been doing to keep our Mainers safe during this pandemic. It's really been kind of life-changing, and we're so grateful to the extent of the cooperation and collaboration among providers, families, DHS, and the CDC and stakeholders. And, you know, I think the fact that we've had so many folks on this call that are interested in getting information out there to help with us as we move forward is in reopening is really great. I'll turn it over to Brenda for some closing remarks.
Okay, thank you so much. And thank you, Bill and Dr. Sears. I really appreciate this, and everybody who's attended this webinar today. And I just want to say, I agree with you, Dr. Sears. I had the same experience with facilities, and they've really said wonderful things about the support that CDC gives during an outbreak. And I know that you're absolutely right. There's so much great collaboration in Maine, which I think really speaks well for us. And I think it's made a real difference. So we're going to be getting the slides out to you. All of you that have joined today, the slides will be sent, and the recording will be available on the Ombudsman Program website. And if there are any families out there that have questions or concerns about visitation that come up, please don't hesitate to call the Ombudsman Program. And again, thank you so much for your presentations today and for everyone who's been here with us today. Thank you.
Yes, thank you so much. We'll be discussing, obviously, getting Dr. Sears on a YouTube channel.
Oh, you just be careful what you ask.
we'll be working to lock that in. And so again, thank you so much for joining us. We will have the materials ready to go by tomorrow. We'll get those out to you. Thank you to the speakers for the time that you took to put materials together and explanations together and going through all those questions. And we really appreciate all the work that you've done. So we will go ahead and bid you adieu. Have a good day and take care of yourselves.